Hi everyone, and thanks for joining us today. Welcome to the Maternity Consortium's webinar on sharing learning on partnership working between the Vcse sector and MVPs with maternal and perinatal mental health services. So unfortunately, my colleague Celeste is not able to host the meeting today, so I've stepped in on her behalf. So Celeste is the Maternity Consortium coordinator and engagement lead. I'm Rob Wilson. I'm head of this the Sands and Tommy's joint policy unit who run the Maternity Consortium. We've got over 200 people registered for this event today from across the Vcse sector, MVPs and the NHS local authorities. So please do introduce yourselves in the chat. It's great to have such a range of people here, given we're talking about partnership working today. Just a brief bit of housekeeping. Please keep cameras and microphones off until you're in the breakout rooms, and recording and slides will be circulated after the webinar. I'm just going to give a brief introduction to the Maternity Consortium and run through the agenda for the day. So I'm going to share my slides. Okay, so firstly, a brief introduction to the Maternity Consortium. So Thomas and Sands co-lead a Maternity Consortium that includes National Maternity Voices, the Pregnancy and Baby Charities Network, 5 Times More, Muslim Women's Network, and LGBT Mummies. The Maternity Consortium is part of the Vcse Health and Wellbeing Alliance, which is a partnership between the voluntary sector, DHSC, NHSE, and the UK Health Security Agency. And the Health and Wellbeing Alliance includes a number of partnerships and consortiums focused on a range of different issues. So the Sands and Tommy's Maternity Consortium is the maternity element of that. The aims of the overall Health and Wellbeing Alliance are to promote equality, reduce health inequalities, facilitate integrated work between the voluntary and statutory sectors, and to facilitate collaboration and co-production, bringing community voices and sector expertise into national policy. We have different projects each year of the Maternity Consortium. So for this year, which is the second year of the Maternity Consortium, we have a project on sharing learning from the Starting Well Fund, reducing inequality in neonatal care, and ensuring equitable access to specialist perinatal mental health community services and maternal mental health services. And it's that last project which we're focusing on today. So just to briefly run through the agenda, we'll start by hearing from NHS England, and then we've got presentations from different groups. So Hearts and Minds Partnership, Kuala North West and Cheshire and Wirral Partnership NHS Foundation Trust, North Cumbria MVP, and Maternal Mental Health Services, Northeastern North Cumbria. We'll have a short break, and then we'll have a presentation from NCT and Cheshire and Mersey Specialist Perinatal Mental Health Services. Specialist Perinatal Services. Then there'll be a Q&A followed by some breakout rooms. We're going to ask you to submit questions in the chat during people's presentations, and then we will collate those together and pose some of those questions to the speakers when we have the Q&A session. Just going to stop sharing my slides. So if you'd like, before I introduce our first speaker, if you'd like to be involved in any of the work we're doing, or anything, if there's anything that comes up today that you're interested in being involved in, please do get in contact with my colleague Celeste, whose contact details I think you will have from the meeting, but we can share afterwards too. So first of all, pleased to introduce the first speaker, Lucy Ellis from NHS England, who is the Perinatal Mental Health Programme Lead, NHS England. And as a reminder, please do post any questions that you have in the chat. And I can see there's a question already about sharing slides and recording. Yes, we'll share slides and recording with participants after the event. So over to you, Lucy.
Thanks, Rob. Hi, everyone. I am so not used to being the presenter, and so have I shared them? And also I've got the thing where I'm totally blind. Rob, have I shared the presentation?
I can see your presentation, Lucy. Yeah. It's slightly discombobulating, isn't it? You sort of speaking.
It's so discombobulating. So morning, everyone. It's really exciting to be here. I'm Lucy Ellis. I'm the programme lead for perinatal mental health at NHS England in the national team. And I'm about to just remind us all of the really high level national policy context. Some of you know this back to front, but I'll just run through what our kind of aims and commitments on perinatal mental health are, just to get us all on the same page. So So just to remind us of where we're at, back in 2014, less than 14 or 15% of the country had a specialist community perinatal mental health service. So the 5-year forward view was sort of the green bit in this little diagram. Over that period to 2018-19, the work was establishing small teams everywhere in the country. The phase of work we're in now, the long-term plan, is a 5-year programme to expand all of those small teams so that by 2023-24, there's a full quality service in every area of the country so that perinatal mental health support can be offered to all women with moderate to severe or complex perinatal mental health needs. So just to remind us all of what that means, the things that we've committed to nationally in the long-term plan are to, firstly, to increase access, so to recruit people into those teams so that they've got the capacity to see in total 66,000 women a year by next year. And then to expand the services that are offered, so to extend so that women can be supported out to 24 months after birth where that's needed, to increase psychological therapies work, so to expand access to therapies including more parent-infant work, couple and family work, to, in order to kind of just try and think holistically about the whole family, to offer an assessment to partners of women accessing services, an assessment of their own mental health, and to signpost partners on to support. And then to establish maternal mental health services. So I think this can be one of the most confusing things. We have, as a whole, we talk about perinatal mental health services, and then we've established these new smaller teams called maternal mental health services. And you wouldn't choose names that confusing if you could. And I think locally, many of you have renamed your MMHS to make it more distinct. But so the MMHS was intended to respond to women whose mental health difficulties result from trauma or loss in the maternity and neonatal context, who weren't treated under the original, there wasn't capacity to treat those women under the original smaller perinatal mental health teams. This slide tries to help us think about the way in which the expansion has happened. So the 5-year forward view, those small teams were aiming to see 42,000 women. The long-term plan, we're expanding to see 66,000. And those blue call-outs on the right-hand side list out the ways in which the expansion is happening. So women with a wider set of diagnoses and needs are included. So reaching women with complex needs associated with the diagnosis of personality disorder, with OCD, PTSD and trauma, with eating disorders, extending out 24 months after birth and establishing the MMHS. And that the work we're doing, that teams are able to do with women should be changing so that there's a greater availability of psychological interventions. So this is my last slide. I realise this is dry and a lot of bullets, but again, just to emphasise that as we're going through this morning, there's these two sets of teams. So perinatal mental health community services are much larger than the new MMHS. So MMHS are small new services working closely both with perinatal mental health community teams and with maternity. And I think the two aims of MMHS are both to deliver services to women who, suffering from trauma or loss related to the maternity experience, but also to support maternity services to provide psychologically informed care. The other thing, kind of just to be aware of in your local context, that because in every area that the wider landscape of services varies, and so the boundaries between what your local MMHS and what the perinatal mental health community service, which women will be seen by which service, may vary. But the important thing is that a service is provided to all the women in the cohorts on the last slide between those two services. This is all really dry and lots of bullets. I'm going to attempt to stop sharing my screen. Not actually sure how to do that.
If you press the cross, there we go.
Has it happened?
Perfect.
Okay.
Yeah, stop sharing. Yeah. That's cool.
Yeah, realise that's quite a mouthful. Happy to take any questions, but I suppose that the main thing just to leave people with is that some people may have been working with LMHS, some people working with perinatal mental health services, and just to hold in mind that there are those two distinct services.
Thanks, Lucy. That's great. That's a really useful overview to start the meeting with. Just as a reminder, so of the course, the purpose of the meeting is, about sharing good practice, sharing learning, and engagement across the sector. So please do ask questions in the chat, and there'll be a chance at the end of some of the presentations where we'll have a Q&A where we'll bring some of those questions together and pose those to some of the speakers. Thanks, Lucy. Our next speaker is Nat Nuttall from Hearts and Minds Partnership. Nat, do you have your slides to upload?
Good morning, everybody, and thank you for inviting me to be here. Let me see if I can share my screen. Can you see that?
Yeah, I can see that. That's great.
Brilliant. OK, so I'm going to tell you a little bit about the Hearts and Minds Partnership. Hopefully you'll have heard of us. If not, then this is an opportunity to find out a little bit more. So we are a collective of 3 perinatal mental health charities across the country who are Acacia Family Support in Birmingham, Bluebell Care in the southwest and Smile Group in the northwest. We are very fortunate to be supported by the National Lottery Community Fund for a 3-year programme, and we're into our 3rd year already. So my name is Nat and I'm lead coordinator of the partnership. I also happen to be co-founder and director of Smile Group, and I work alongside an amazing team of Sarah and Abby, who are respective coordinators in the Midlands and the southwest. So we have an overarching aim, which is to support, connect and celebrate all the incredible Vcse services in perinatal mental health across the country. And we're doing this by 3 specific work streams. So the first of which is the creation of an interactive digital map of safe quality grassroots PMH services across England. Hopefully you'll have heard of the map. If not, it's available via our website. I'm a mum with lived experience, and I know that when I had my child and was unwell, I would have really valued the opportunity to have a central resource to look for local services in my area, and that's really the rationale behind the map. It's being populated organically. We've had 70+ checklist submissions already, which is amazing to see. We did put in a bit of due diligence because we felt it was really important that services that are emerging particularly are protecting themselves and their beneficiaries. So we do ask a few basic questions around safety, around adult and child safeguarding policies, DBS, supervision, the kind of things that you need anyway if you're a service that's going to be going for funding. So the map is continuing to be populated all the time. We added 2 more services yesterday, and the aim is that we will be able to strategically map the gaps to inform commissioners and people who are looking at generating new services. The second work stream is the development of trusted spaces, very much like this one, to bring people together, to share the successes, to talk very openly about the challenges that we're facing in the reality of this sector. We launched something called Conversation Space, which is a monthly free online meetup for all the VCS services in perinatal mental health, and that's been really well received. We cap it about 20 attendees just to keep that chat really intimate and so people feel like it's a trusted, safe space to share stuff. And on the back of everything that we've learned and we've heard and translated back, we're in the process of developing some online training, so some modules that are aimed at supporting the emerging and established VCS services, looking at a whole range of themes from governance to safeguarding to funding, which is the word on everybody's lips. So, and we're also hosting a national event in January. It was actually postponed from September, and that's pretty much at capacity. So we look forward to seeing everybody in Birmingham in January. Hearts and Minds really is about developing that equilibrium between drawing on all the amazing stuff from the grassroots sector, which is that incredible passion that drives it, that profound relational experience between services and beneficiaries, the connection that we all share and the integrity in the way that we work, and underpinning that with real rigour and rationale behind what we're doing, looking at that quality piece so that we can start articulating the impact that the sector is having nationally, and of course mapping the gaps. And all of our work, and that goes for everybody in this conversation, really is focused around ensuring that families have a seamless experience. So some numbers just to keep you up to date with what we've been doing. We've had 74 Vcse services engaging with our MAP sign-up process, which is great to see, and that's going up all the time. 65 are now published on the MAP, so parents and healthcare professionals can use the MAP as a means of looking for local services in your area. 64 Vcse services have taken part in our conversation space, which is great to see. And we have actively engaged in our outreach work with over 105 grassroots services. So constantly looking for opportunities to go out there, find out what's on the ground. So please, please do, if you're not already on the MAP and you are a service or you know of a service in your locality, please point them our way, because we want to make sure that it's really, really a robust kind of resource for people. And this slide is really pertinent to the conversation that we're having today about partnership working, which we know is absolutely instrumental. And what we do know is that families thrive when they are supported by an integrated blend of services. So it's not just about statutory, it's about complementary services, holistic services like the incredible work of the Vcse sector. So our work is to be busy, to connect with people, create opportunities to meet all of you amazing people here today. We're already working alongside the Alliance, NSPCC, and this is by no means an exhaustive list, and obviously Maternity Consortium today. And really, my call to action is that this is an opportunity to get to know each other. So please do get in contact with me and the team. And likewise, I'd love to get in contact with you guys so that we can find out a little bit more about how we can work more closely together. I've rattled my way through those slides. I always talk a little bit too fast. So here's opportunities to connect with us. We like to hang out on social channels, so you're more than welcome to find us there and engage that way. Thank you very much. I'm just going to try and stop sharing my slides. There we go. Hopefully that's worked.
Yeah, that's all fine. Thanks, Nat.
Thank you.
Thanks, Nat. That was great. I'm just going to introduce our next speaker. So our next speaker is Stephanie from Koala Northwest and Natasha, next speakers, I should say. Stephanie from Koala Northwest and Natasha from Cheshire and Wall Partnership NHS Foundation Trust. So over to you, Stephanie and Natasha, and just as a reminder to keep those questions coming.
Oh, can you hear me, Rob?
Yeah, I can hear you fine, thanks.
Yeah, and you can see us okay.
Yeah, I can see you perfect.
Thank you so much. It's definitely off-putting not seeing anyone. I think actually I'm quite interactive and I love that interaction. So yeah, so hello everyone. I'm really grateful to be here and joining everyone to think about working in partnership with voluntary, community and social enterprise sector to reduce health inequalities across maternal and perinatal mental health services. So who are we? So my name's Stephanie Leeson. I am the early years lead for Koala Northwest, and I'm also joined by Natasha Coombs, who's the clinical lead for the specialist perinatal mental health service. So I'm now going to introduce Natasha, who's going to talk to you a little bit about specialist perinatal service.
Hello everyone. Thanks for allowing us to share this today. I think my team is basically the introduction that Lucy gave was absolutely fantastic. So I'm just going to go a bit more in depth with that. We are a specialist perinatal mental health team. We've been in CWP, so I work for Cheshire Wirral Partnership. And I've worked here for just over 18 months. The team's been around for about 5 years now, so we are still very new and established, but it's increasing and you know, it's developing at a really, really fast rate. So we are a secondary mental health service within the NHS, and we work with parents who are pregnant and up to 2 years after giving birth and are experiencing moderate to severe mental health issues with complex needs. We're built up of various professional disciplines, which is the image that you can see to the right, with ever increasing. So we are getting CBT therapists at the end of this year. We're also getting advanced nurse practitioners. So it is ever increasing in the roles that we have within our team. We do cover 3 areas within our patch, so we cover Wirral, Cheshire East and Cheshire West, and I know other specialist perinatal teams have a massive footprint as well. We offer a variety of therapeutic clinical interventions to help individuals manage their mental health and improve their daily lived experience. So this can be anything from mood monitoring, medication intervention. We do something called match care, which is CBT based to look at anxiety, depression, intrusive thoughts. There's lots and lots there. And we work to encourage a better relationship between parents and their children, with a view that early intervention to promote better outcomes for parents and their children. So hopefully by coming into services such as perinatal teams, what we're doing is we're preventing people accessing more in-depth and invasive services in the future, such as crisis interventions. You know, we're really trying to implement sort of that care as early as possible.
Thanks for that background, Tash. So a little bit about Koala Northwest. So we are a family support charity. We've been supporting families in Wirral since 1999 and recently within Cheshire West. And we were funded by the Vcse Health and Wellbeing Fund, I think it was 2.5 years ago now, to think about developing this 1001 Days programme. So it's a pathway for infants and parents, and also a network for professionals. And it was bringing together health, it was bringing together, you know, our council services and our third sector services to think about those first critical 1001 days, and thinking about a central kind of resource, a central website flyer for parents where they could access all the different services that you might need in those first 2 years of your baby's life. And the consultations with parents were really, you know, we wanted one central point. We didn't mind who was offering that support, but we wanted somewhere we could go to easily and scan the QR code and it could bring up everything that is available. And what's really crucial about that is one of the key areas, one of the outcome areas agreed by the Health and Wellbeing Fund was to think about the improvement of perinatal mental health. So the ease of accessing that support for families. And as a result of this developed our Parent Infant Mental Health Service, which is universal and targeted support across 5 of the most deprived wards on Wirral. And I feel really proud of this work because from that developed our working relationship with the specialist perinatal team. We also felt really, it was really important to us to connect with our Maternity Voices, our maternal mental health midwives, and also recently the Silver Birch, which is a maternal mental health hub. So this is what began our working together. So I know Tash is going to talk to you a little bit about our development of how we began to work together and kind of understand each other's teams.
Yeah, so when I came to the team, one of the things that I was really keen to work on was I was a social worker in Wirral previous to working with the perinatal team. And I was really keen to establish relationships with services really early on. So when I heard about Koala and they'd recently established in the Wirral, I was really keen to sort of get involved with that and really look at what outcomes and better outcomes that could have for our patients and obviously the people that access Koala as well. So to do that, we obviously had to have an understanding of each other's service. We were included in the same perinatal network meetings. We incorporated each other's training to our teams. So Koala would deliver training to perinatal and we would deliver training to Koala. We'd work together really closely. So whether that was joint visits, whether that was joint working, and we also established community clinics. So, for example, I would go and do assessment clinic for Koala, and what it was it was a good link in to get the parents into Koala to say, you know, this is what it's all about, this is what it looks like, and actually really take a step to accessing those community services outside of secondary care mental health. And learning from partnership work as well. So the cases that we have worked, we will often sort of get together and discuss and say, you know, this worked really well, or actually this needs tightening and this could have done with this intervention. So it's always about keeping open discussions between NHS services and voluntary sector organisations to really ensure that that joint working is going as smoothly as possible and those parents and children are getting the best outcomes.
Tash. And I think coming back to the community clinics as well, where we think about, you know, reducing health inequalities, you know, feedback from families saying having, you know, the specialist perinatal team and their appointments in our local hub, our community hub, if you like, and being able to see my maternal mental health midwife, or, you know, as a paternal mental health, you know, the Silver Birch team, actually having that in the heart of the community is vital for families, because some families, you know, travelling to the local hospital or to an appointment, you know, outside of their local community, you know, has a cost element, has a barrier. So it's been really successful, and the feedback from families has been really positive. So thank you. So hopefully if the audio works, I'm going to jump in straight with a case study. And the reason that I want to talk to you and share this case study and bring Jess's voice here today is because this was a case and a family that kind of we worked with very early on in developing the service, really. And it really stood out because actually alone we can do so little, but together we can do so much. And when we're thinking about, you know, kind of learning from practice and learning from working together, this really sticks in mind, because this family's journey and I suppose the success and the outcome, the happy outcome, the positive outcome, wasn't just solely because Koala were working with this family, because a voluntary sector organisation were working with this family. This was because we had the perinatal team involved and Koala and a selection of other services, and the communication was there, the working together was there, the trauma-informed approach to care was there. We were able to stop, reflect, what are the barriers for this lady? Let's learn from a history of why, you know, she maybe struggled to access care. So I just want to introduce Jess. She was 26 years of age at the time of referral. She was 24 weeks pregnant and living in an area of high deprivation. She had suffered a history of awful physical abuse from previous partners, accessing care through the specialist perinatal mental health team due to post-traumatic stress disorder and just depressive episodes. And Jess was really reluctant to work with services and health professionals and really struggled to trust anyone. She self-referred to Koala Northwest to access some antenatal support before her baby arrives. And we offer like a 3-week womb to world antenatal program, really just to think about connecting with baby, the transition from womb to world for baby, the support network for you postnatally. What does that look like? We were able here to build up a therapeutic relationship with Jess, and she was then felt that she was building that trust with services. Over time, we were able to kind of link in, and you know, Jess was very reluctant about having a health visitor, for example, see her postnatally. She was really reluctant to have anybody come in, you know, thinking about the postnatal period, observe her and baby. She was just really struggling with allowing anyone into her safe space. So I spoke to the specialist perinatal team, and they have a specialist perinatal health visitor, and we discussed, you know, thinking about doing a targeted antenatal visit together. And Jess kindly, you know, said, okay, yeah, you know, I'll allow you guys to come in, and Steph, I trust you. You can bring the health visitor from the specialist team too. And that formed such a lovely relationship. It made such a huge difference to Jess. I was also able to link in with her psychiatrist within the specialist perinatal team. Sorry, all these words are such a mouthful. But it was really, I think that was really crucial. So I'm going to stop talking now. I'm going to let you hear from Jess about her story. Tash, you tell me if you can't hear this.
Okay.
If my voice accounts for anything, and if there are any women listening who want to engage with services, I strongly recommend Koala Northwest and the Perinatal Mental Health team if you suffer with mental health illnesses. I fell pregnant at the age of 26 carrying my firstborn. I am a survivor of physical and psychological abuse from men and certain services. I was extremely reluctant to work with any services by my experience from the past. Following this, due to being personalised over my mental health and past experience of domestic abuse, I self-referred myself to Koala Northwest, engaging with my psychiatrist and Steph, who helped me massively along my pregnancy journey. I finally felt listened, understood and diagnosed rightly, as in the past I was wrongly diagnosed with emotionally unstable personality disorder, when in reality I am a survivor of severe physical and psychological abuse, which has led me to have complex PTSD. I want to thank my perinatal mental health team for believing in me and standing by me to have my broken heart fulfilled by a beautiful soul that I have created, that social care were trying their very best to remove from me. I honestly don't know and dread to think what would have happened if I never had my perinatal mental health team and Koala Northwest with tomorrow's women behind me 100%. These are the services I personally can vouch for. I have my beautiful baby, my whole world, safe with me at home, and I have Koala Northwest and my perinatal mental health team to thank for that, as they were with me along my pregnancy journey the whole entire way. So yeah, thanks, Steph.
Okay. So Jess really wanted to be able to be here and share a story, and obviously it's, you know, very anxiety provoking. So she asked if we could share her voice, and I think it's so powerful because it's about recognising for service users, for families, that it's about, you know, no service alone, you know, can support families. It's about together we can do so much more. And thinking about trauma-informed care, you know, those lines of communication between different services, whether it be voluntary, you know, whether it be our specialist perinatal team, other sectors, it's vital. Okay, let's move us on.
If my voice.
Okay, so working with wider services. So I guess for us, what was really key was about, you know, as a voluntary sector organisation and working with a specialist perinatal team, you know, we have lots of links with other voluntary sector organisations, particularly within the Wirral. So it's about having, you know, this perinatal frame of mind and sharing this vision, and that we want to be able to improve the access to perinatal care for women, for birth and people, for their families. So I felt, you know, this development with working with the specialist perinatal team, I could say to the other voluntary sectors, to the other organisations in our area, hey, you know, we've linked in, it's working well, you know, do you want to join? So actually what we were able to do is to get the other voluntary sector community organisations in our area that work with families in the perinatal the perinatal period involved. We were able to then, you know, lean on each other, use and share some of those resources with the wider sector. So we have a fabulous organisation on Wirral called Wirral Multicultural Organisation Centre, who have access to translators. So we were able to think about, you know, working together within the perinatal period and sharing each other's resources. We were also really able to share the knowledge around recognising the risks in the perinatal period, thinking about that perinatal mental health pathway, and thinking across the sectors about, you know, who do we refer to, and educating not just our service but other services. We were really lucky that our clinical the clinical network manager for the perinatal team recognised actually how important it was that within our service as well, we had a PIMS champion that could also access some further training and then cascade that learning to, you know, the wider sector. So I felt that that's been really very important. Also, I think involving the wider sector, we can learn from each other when we're thinking about health inequalities across the perinatal period. You know, there was gaps in services and barriers that maybe weren't on my agenda, maybe that I wasn't thinking about, that the specialist perinatal mental health team weren't thinking about. So we could really kind of have these open discussions and reflecting and learning from each other. So I just want to share a slide. This is some feedback from some professionals when we delivered our PIMS champion trainings of a perinatal and infant mental health multi-agency training. I actually co-delivered with one of the team from the specialist perinatal team. And it was the first time we'd really thought about doing some multi-agency training across the sectors and the teams. And it was really powerful, and I wanted to share this because what really stood out for me was the common themes and feedback from the practitioners. So we had some health visitors, some of the specialist perinatal staff, some of the staff from Koala Northwest that were all working with families in this perinatal period. And what was key is they were saying, during duct working, communication is the thread that runs through for me, connecting, knowing what other agencies offer. Multi-agency work is awesome. It was so powerful that it's now helped us as a team think about, you know, when we're offering perinatal, parent-infant mental health training, that we will involve, you know, multi-agency professionals, that we will think about, you know, having that space to learn from each other. So I just really wanted to show you this because I felt it was really important when we're thinking about training within our services as well. Okay, I'm going to pass you on to Tash to think about service users at the heart of why we're working together. So not just why does it, you know, why is it on our agenda, why is it important that we work together, but actually holding in mind the benefits for the families themselves.
Absolutely. And as Steph just said, it's so important to work together, but actually, you know, why are we doing it? And the reason that we established this joint working between Perinatal, Koala Northwest, the mental health midwives within our local hospital within Wirral, the health visitors, all these kind of agencies, we join together. And, you know, and these are the outcomes for these families and for these children. So people and their families are seen quicker and appointments are in their home or local community. So it's reducing that health inequality that actually they're having to go to a hospital or a clinic, something that can be very triggering and anxiety provoking for a lot of our patients. You know, we're bringing the service to them. It is about care in the community. The support has more access points. So whether that's us, whether that's Koala Northwest, these parents hopefully will always have someone that they can go to. And this isn't just about being actively involved. This is about making parents aware. You know, are you aware of Koala Northwest? Actually, you know, you can self-refer to them. So it's about education to parents as well and making them aware of the services around them, connecting with a wide range of community groups. I mean, you know, I think anyone in this job will constantly learn about new services every single day. And great, you know, I can always see in the chat that there's some great services already saying, you know, access our website, have a look. You know, it's always so beneficial to really get that wide range of services because, you know, it will always benefit parents. And the needs are met through holistic approach. So sometimes having one approach, you know, it's not saying it's a bad thing, you know, any service is a great service, but actually it provides a different viewpoint and it provides a different way of looking at things, which can also be really beneficial. Working with different specialisms. So, you know, we've got the perinatal team who can obviously sometimes be quite clinical in their approach. Actually, Koala Northwest really working on the ground and going, have you thought about this? This is their daily lived experience. It's not just a medical approach, it's a social approach as well. So actually learning lessons from each other, right service at the right time, early intervention, getting in there really, really quickly. And information sharing across the team, because what we've really discovered is when we're accessing different services, if we're not working together, these patients, parents, families are having to tell their stories numerous times and how traumatic, how difficult for them to really sort of relive trauma over and over again. And while that happens every time that parent, that person tells their story, it becomes more invalidating and more important to them, you know, and just they start talking about it because they've talked about it so many times, they become quite blasé, and actually we're not getting to the heart of the problem. Early intervention, I've mentioned, and reducing health inequalities within the care and the community, being more accessible, being there for parents, whether that's through perinatal, whether that's through Koala, whether that's through our crisis line, making sure that we are available 24 hours a day, 7 days a week for these people who need it most, and culturally adapted services as well. So what we know from anyone who's familiar with Embrace and sort of learning lessons is, you know, is that one of the things is that BAME communities, you know, are not accessing services how they should be. You know, they are at more risk of a health inequality. So actually really putting that at forefront and thinking, you know, are we taking people's cultural needs and why aren't we reaching these people? It's not about the people reaching us. You know, that's the health inequality. Let's think about how we are reaching these people and how we can work to benefit them in the way that they need to. Thanks, Steph.
No, please. So I didn't want to kind of come on today and, not kind of talk about some of the challenges of working together, because there are some, aren't there, Tash? And I think the initial challenge was knowing who to contact from which service initially and form that, working relationship. And it takes people that are passionate about perinatal mental health, about parent-infant relationships, that, it's... Oh, there's a bit of interference then. It's not just a tick box to work together with other organisations. You need people that really can see the benefit and are passionate about, this sector. So actually for us, it was about forming those relationships. I think we've been really lucky that since the development of the specialist perinatal team, they've always kind of seen the value of the third sector organisations, and kind of always, before we were self-referral, would refer families to Koala North West. So we were really lucky that we did have a point of call to build that working relationship. But I totally, understand and can see from possibly other organisations that are on here today that the first initial hurdle sometimes can be forming that relationship. And jumping, to the end here, thinking about repeating training for new starters. I think one of the things that me and Tasha spoke about recently is that as our teams are ever expanding and getting bigger, it can be really difficult to make sure that new staff that are inducted understand the working relationship, understand and know who the different community organisations are, what each service does. Who is the specialist perinatal team? It's my responsibility to make sure new staff members understand the pathway, the referral process, recognise the signs when you're working with families, the red flags, and are able to then, know confidently how to make that referral to the specialist perinatal team. Time constraints. I think, everyone that is on this, webinar today will understand and maybe relate to it's so difficult when whatever sector you're working in, if within the perinatal period, that there's huge demands and there's huge time constraints. But I think, we've been really persistent, haven't we, Tash, that, we make time, that we factor in, for example, the multi-agency PIM champion training, that when we're thinking about delivering that training, that we block out time. And it's tough, but we have to make sure that we, that we're quite firm, I suppose, with scheduling. And then also for voluntary sector, for community organisations, third sector, funding and short-term contracts can be really difficult, because you build these working relationships, you start to see that you are reducing health inequalities for families. You can see the benefit of a parent infant mental health service within a voluntary sector organisation, and then funding comes to an end, and it's difficult because you want to keep the service users at the heart of what you do, and you can see that something is working. So how do we sustain that? But I think we have a staff team, we have our CEO, we have a whole host of staff that are committed to securing future funding. Is there any challenges there that I've not mentioned, Tash, that you want to mention?
I think you've covered it, Steph. Yeah, I think you've smashed it.
Okay. We are coming to the end, guys, sorry. I just wanted to share some service user experience, and I think it's really powerful to get the family's voice. Some feedback recently was that a family had shared with us that, they felt the support from the PIMS coordinator had really helped them so much. It kind of just lightened that load, having someone to talk to, that emotional support, providing, those essentials when families are living in poverty, clothes for their baby, a baby gate. But also what was really key here, which is why I've shared this today, was the fast track to mental health team for diagnosis and support. And what this family is referring to, I think she'd been the GP and struggled to kind of access some support within the perinatal period for mental health. She felt that there was lots of closed doors, and she felt that she wasn't kind of getting anywhere really. And I was quite concerned when she was referred to us that she was really struggling within the perinatal period. And when I reassured her that actually we can make that referral to the perinatal team, she was just delighted. it was quick, it was picked up really timely by the team, and she just fed back that she just felt that it was seamless. I don't think families realised that sometimes accessing a voluntary service, that they are able to make, you know, a referral into the perinatal team. And I know this is dependent on areas and pathways, but within our particular area, I think this is something that we're really proud of. It's about accessing perinatal care quickly and timely. Okay, I'm going to stop talking now. Ash, I don't know whether you want to introduce Sophie, one of your peer supporter, and her feedback.
Yeah, so one of the roles that we've had come to the perinatal team recently, which is absolutely phenomenal and invaluable, is peer support workers. And they are members of the team who have had lived experience with mental health. Now, Sophie Tolley couldn't be here today, but she did put together a lovely voice presentation. So I really just want to, you know, as important as people's voices are, just really share her story. And then we are at the end, we can go to questions. I can see a couple of questions in the chat, so I have noted them down, and I will do my best to answer them as quick as possible to keep within time constraints. So yeah, here's Sophie's story.
Hello, my name's Sophie Tolley, and I'm one of the peer support workers on the CWP Specialist Perinatal Mental Health team. I started working for the team in January this year, having been discharged from the same team as a service user in October 2021. I've been asked to share with you a brief overview of my history within the service and the importance I feel of joined up working. So my first experience with mental health difficulties came in 2012 when I experienced anxiety, panic attacks and depression. I sought a private CBT therapist during this period, which helped me to reframe my negative thoughts, and I began to recover slowly alongside antidepressant medication. This experience was further amplified when my dad unfortunately passed away in 2013. This life-changing bereavement has had a profound impact on the rest of my life to date. I believe his death, plus childhood trauma and a stressful job as a teacher, led to my first psychotic episode in 2014, where I was experiencing auditory voices, hallucinations, both visual and somatic, and I had strong delusions about being filmed, which made me extremely paranoid. I was assessed under this community mental health team and then referred to early intervention and psychosis team, where I was assigned a care coordinator who was an occupational therapist, and I was put on antipsychotic medication. And that's all of that happened when I lived in Bromley in London. In 2016, when travelling in New Zealand, I experienced my second psychotic episode and ended up as a voluntary inpatient in a mental health hospital over there. Once again, I experienced similar symptoms as described in the previous episode. I went back on my previous medication and returned home to the support of the early intervention team. In 2019, I moved from Bromley to Cheshire and began trying to conceive. This was when my journey as a service user within the Cheshire and Wirral Specialist Perinatal Mental Health team began. I've been so fortunate to receive a wide range of support and interventions from the perinatal team. This has included preconception counselling, CBT and mindfulness techniques, a detailed birth plan. I was assigned a specialist midwife, a psychiatrist, a mental health practitioner. I accessed crisis line. I was invited to baby massage, a compassion-focused therapy group, and I took part in the Lullaby Project. And this is why I believe I now have such a great relationship with my son and why I'm now in such a better place in terms of my mental health. So I gave birth to my son in 2021. Postnatally, I really struggled with my mental health. And because I was suffering physically, which meant that I hadn't slept for several days, which has always been my trigger in past episodes. And as a result, I nearly tipped into postpartum psychosis. But with the support of the team, we managed to prevent this. And with the interventions I previously listed as well. Things got progressively worse when my son was taken into hospital at 2.5 weeks old. He had sepsis, along other things. And I was then because it was lockdown and I had to choose one parent to accompany him, I decided, based on how I was feeling at the time, that it should be my husband that went with him. And consequently, I was left alone without my husband and baby for about 3 weeks. Again, if I wasn't under this amazing team, I genuinely don't think I would have got through that period and that I would still be here today. Luckily, my son has made a full recovery. I genuinely think it's so vitally important that health services work together and within the community in order to support our service users and their families. From my experience, it was really clear that there had been strong communication between the perinatal team, but also in how they had linked to the resources of the wider community. For example, I was invited to a birth planning meeting when I was in my 3rd trimester, which was over Teams as it was during lockdown at the time. But from memory, there was my mental health practitioner, my psychiatrist, a specialist midwife, my community midwife, and possibly one other practitioner. During the meeting, we all worked together to come up with an ABC plan that felt right for me based on my past experience of mental health difficulties. I didn't have to repeat my story either. It was clear that they had all been at least briefed on my history, and I felt extremely empowered during this process. As a result, although my birth did have its difficulties, I felt that my birth plan was actually taken into consideration from the midwives at Leighton Hospital, which made a huge difference. Another example was when one of the leaders of the Compassionate Focus Therapy group found out that I enjoyed singing, as I had mentioned it to in one of my self-care tasks during the group. She then asked me if I'd be interested in joining the Lullaby Project, which was with an organisation called Live Music Now. This involved being paired with a musician, and together we designed a personalised lullaby for my son. I wrote the lyrics and Pip, the musician, wrote the melody and incorporated several instruments. I then performed this live alongside Pip, watched by an audience including my son and husband. It was an incredibly proud moment for me, and the whole process was so empowering and has increased my confidence as a mum so much. It's also helped with our bond and connection, and I still sing that lullaby to him, and I truly believe it offers him comfort and helps him to sleep. The reason I was fortunate enough to access the Compassion Focused Therapy group was because I'd been in a baby massage group, and that practitioner had put me forward for it. And I'd found out about the baby massage group through my mental health practitioner. So that's just one example of how the team's multidisciplinary approach has had such a positive outcome for me and my son. One of the many things I appreciated from this team and the community was not having to repeat my story over and over again. I remembered going into a lot of detail about my history during my preconception counselling, but from there, once I fell pregnant, that's when I continued to access her as my psychiatrist, and the other interventions followed as a result. But I don't remember having to really revisit my past from that point on, because it was clear with my permission that the team had shared relevant information with each other. I then felt I could divulge further with my mental health practitioner, for example, if I wanted to, on my own terms. Prior to my experiences with perinatal, I have had to repeat my story several times when I've been in a really vulnerable place mentally for various teams, and I found it just soul destroying, to be honest, and I felt re-triggered from my past trauma. So it was really refreshing that I didn't experience that as much within this team. I also found postnatally that I was really struggling with my memory and remembering who I told what to when I spoke to the various practitioners. The team dealt with this in a really kind and compassionate way, and I felt really reassured that it wasn't expected of me to get everything right and in sequential order, but they were just there to support me in the way that I needed. I felt really contained and held during that time. Saying that, though, part of my role now is to repeat my story, but that comes with the territory of being a peer support worker, and that's my choice and decision and on my own terms, and I get to pick and choose what parts I share with the service users, and I can do it in a way that hopefully offers that hope and proves firsthand that recovery is possible. And one part of my role that I really do enjoy is liaising with colleagues, both within my team and the local community, and being able to signpost service users to the amazing facilities and groups that are provided by organisations such as Koala Northwest, which I know from speaking firsthand to families I work with, what a positive impact they have had on helping them in that vital postnatal period. Finally, without the constant support from the team and from my psychiatrist in my discharge meeting suggesting that I go for the role as peer support worker, I wouldn't be here sharing this with you today, and I will be forever grateful for that. Thank you for listening.
Awesome. So yeah, so that's Sophie's voice, and she's absolutely amazing, so inspirational to so many of our families and our women. She's absolute legend. So yeah, you know, the passion's there. We've all got the same passion. We all share it. You know, we just need this to keep it in mind that, you know, we're all really busy, but actually working together just makes our job so much easier, and it makes such a better experience for these families. Thanks, Steph. So yeah, so thank you so much. I know we're really running behind, so I'm just going to whiz through a few questions if that's okay, Steph. I know that Joan Atkinson asked about nursery nurses and whether we considered recruiting. Yes, we have. They're in the next wave of funding, and we will have nursery nurses at the end of this year, hopefully beginning of next year. And Laura Weatherhall asked, but I think it was more to Lucy, about lowering thresholds. Now, one of the things that we've done is actually really lowered our threshold. So even if we think that they're not meeting criteria for a secondary care service, we will actually still do a full assessment. One, because it gets a full story, it's an enhanced assessment, and two, because we can link in with the relevant services and share that assessment so they don't have to repeat their story. So we're trying to use our service more as a perinatal hub to try and get all these women in, get them assessed, and really think about what the best intervention is for them, whether that's a secondary service, whether it's primary care, or whether it's voluntary. So I don't know if all teams practice like that, but it's something that we've certainly started to take on, and we've really seen a difference as well. And then Tiffany has asked how we count it in our access rates, Steph. So what we do, for example, if we want to do a joint assessment, or we do an assessment clinic with Koala, what we will do is we normally book 3 or 4 ladies in at a time, and we will ask the joint practitioner to refer all those ladies to the perinatal team, so we can open them on our system, and they count then in our access rate. So that will count as 4 assessments. So any lady that we do sort of a joint assessment on, they are counted in our access rate if it's at that first point of call. I hope that makes sense and that's answered everyone's questions. Lots of beautiful comments in the chat, so thank you so much. You know, it's something that me and Steph are really passionate about, and will continue to be really passionate about, and work with these ladies to the best of our ability.
Thank you, everyone. Thanks, Tash.
Thanks, Stephanie. Thanks, Natasha, for such a brilliant presentation. If anyone does have any more questions they want to answer in the chat, we'll have a Q&A session with all the presenters a bit later on in the agenda too. And also thanks to Jess and Sophie for sharing their stories. I think I agree with one of the comments from the chat that there's a really clear message there about the power of working together and the impact that can have. I'd now like to introduce our next speakers, who are Anne Broadbridge, Catherine Parker, and Sandra Guys from North Cumbria MVP and MMHS Northeastern North Cumbria. Over to you.
Great, thank you very much, and thank you for having us here today to share our work. Rachel, could you move on to the next slide, please? So my name's Catherine Parker. I'm a clinical psychologist, and I'm clinical lead for maternal mental health services across Northeastern North Cumbria. And I'm here today with this team that's up on the board, so with my colleagues, and I'm going to be talking today with Sandra Guys and Anne Broadbridge. And we've also got Rachel McDonald with us today, who's played quite a key role in putting this presentation together. So thank you as well, Rachel. Ange and Sandra will introduce themselves later, but just briefly, Sandra has got many titles and many different roles. So is the service user rep for our local LMNS and co-chair for the North Cumbria, two North Cumbria MVPs, so both the Northeast one and the West one, and it was also co-chair of the maternity engagement group. And then Ange Broadbridge is the maternal mental health project manager in Ways to Wellness and is leading on our prototype project with the Vcse. So it's great to be here together today. So I'm just going to give a brief introduction to maternal mental health services. I'm sure many of you will have this information already, but it's just useful to put the work and our collaboration into context. So the aims of maternal mental health service are the three that we've got up here on the slide. The first two generally come from the national initiative, and the third one is one that we've added locally for our own purpose. So maternal mental health services, we're being set up to offer specialist assessment and evidence-based treatment and psychological interventions for women who are experiencing moderate to severe complex psychological difficulties that arise from or relating to pregnancy and childbirth. And the aim is for those services to be integrated within the maternity pathway and to build on existing birth reflection services as well, but also to form part of the wider perinatal pathway, which includes other NHS organisations, local authority organisations and third sector organisations too. And then the last one, which is going to be a big focus of our presentation today, is that the new service and the new pathways to be co-produced with a focus on personalised and trauma-informed care and making sure that we've got those connections across the system. So next slide, please. So this is just, I guess, an overview of who we're seeing within maternal mental health services. So I described before around it being relating to arising from maternity experiences, and we're splitting that into three main groups, which is around trauma, relating to the maternal or perinatal context and neonatal context, loss, perinatal loss that's happening in that same context, and loss for many different reasons at many different stages of pregnancy, and then fears and phobias, where they're having an impact on someone's maternity care. So that might be a fear of childbirth, but it might also be other fears and phobias of fetal medicine or hospital environments that we can work with. So next slide, please. So I know Lucy earlier gave a bit of an introduction on the policy context and the link with the long-term plan, and so I won't cover that in much detail now, but we know that maternal mental health services are part of the long-term plan and referred to as maternity outreach clinics within that document. And also a strong link with the recommendations that are coming out of the Ockenden reports, so particularly around there being robust integrated pathways around maternal mental health services that contribute to supporting women who have complex pregnancies, but then mechanisms for identifying psychological distress, clear pathways for referral on, timely access to psychological support, and that psychological support being delivered by psychological practitioners who have the appropriate expertise. So I guess that's the policy context behind what we've been doing. Next slide, please, Rachel. Thank you. Between 2020 and 2022, there were a number of early implementer and fast follower sites that have been established across the country. And within Northeastern North Cumbria, we've got 2 pilot sites, which I can describe a little bit about in a moment. And then the aim is for all areas to have an established maternal mental health service by 2023-2024. And so we've been working with the Perinatal Mental Health Network, so that's where Rachel and I seconded to with this project, alongside the LMNS and the Mental Health Ops Group. And over the past 18 months, Rachel and I have been working with the rest of the team as well to prepare the foundations for maternal mental health services and set up evaluations and develop recommended models. And that's been a big team effort, again, across the NHS, across the Vcse, across the local authority. 2 pilot sites have been set up with the ambition to see 2% of the birthing population. We've discovered that, like many other areas, that the demand's much higher than that. So we're actually forecasting to see about between 4 and 5% of the birthing population now. And the 2 sites have been in South Tyneside in Sunderland and in North Cumbria. And alongside that, we've had a number of different initiatives. So an independent evaluation with the Applied Research Council at Newcastle University, and they've also commissioned a piece of work to gain further insights into barriers to access, particularly from people who are might be disadvantaged for different reasons, and from Black and Asian ethnic minority groups. We've got a task and finish group set up to oversee the work. Again, it's got membership from lots of different sectors, and both Ange and Sandra sit on that task and finish group. And then a Vcse funded, we funded a Vcse project to look at prototype models for link worker and peer support. And as I said, Ange is leading on that project, and we'll describe that in more detail later on. So next slide, please. So this is just my final slide before I pass over to Sandra. One of our key aims was to think about, I guess our key assumptions was the importance of integrating psychological care within the physical health and the maternity pathway. So that's been one of the core things that we've kept in mind, and that to be able to do that successfully, that's involved us thinking about how this new service fits within the wider system and is joined up with the work from the Vcse and with other NHS organisations. So that's it from me, and I'll pass over to you, Sandra. Thank you.
Thank you, Catherine. Hello. Just to give a little bit of context with all those different titles I had, basically it means that I'm a local Maternity Voices Partnership chair in North Cumbria, but I also have a role within our LMNS, which is a very large LMNS with 10 MVPs, sort of sitting at that level as a link between MVPs and the board as well. So that's given me the opportunity of having that sort of strategic overview, but also working locally in my MVP chair role with implementation of the project as well. So what's the golden thread of the Northeastern North Cumbria approach? Well, basically it's personalisation and personalised care at the heart of the planning and the service design, and it's underpinning the work to engage and involve and shape mental health, maternal mental health services. We were involved as service user voice reps right from the beginning, and at that strategic level with the network programme management team to plan the fast follower pilot sites. And we did actually sort of spend meetings discussing what co-production is, what it should feel like. And later on I'll show you that diagram of how co-production has that fuzzy front end, and how do we make sense of it and make it work for the project that we were undertaking. But that was a really useful foundation really to have those discussions. Local MVPs were involved in shaping the fast follower projects in Sunderland, South Tyneside and in North Cumbria, and have been involved in other ways in the development of the work. And we've shared ideas about information people receive about the service, what it should be called, what and where it should be, and we'll give a little bit more detail about that in the next slides. But importantly about how people find out about the service to support both the preparation of materials, which are going to be shared with women. We had some sessions actually around the Year of Care programme, which was something that was used in another part of the Northeast to look at long-term conditions, and it was linking clinical issues and challenges along with persons' lived experiences, and using those experiences in focus groups to understand and redesign pathways so that it met needs more carefully. So these were adapted for looking at the development of maternal mental health services and involving people with lived experiences in designing those materials. Okay, we also ensured that service user voice was at the heart of the new service governance structure, as Catherine's already touched on, with the Northeast North Cumbria Maternal Mental Health Task and Finish Group, and ensuring that we capture all voices and close loops and take action on feedback and information. There's been excellent listening throughout this whole process. So the governance works when you have that excellent listening supporting it, so that what's developing is genuinely co-produced. If we go to the next slide, please. So these were the key questions that were taken, and they've been a bit of an iterative approach in terms of looking at these questions and then taking them into that sort of year of care focus group listening thing. So what do you think about the name? In fact, there was quite divided views about what the name should be, whether it should be including the word mental in it or not. And how would you like to find out about services? Absolutely fundamental. You have to ask the people who need those services how they'd like to find out about it. What information would you like to have, or what do you need to help you decide if this is the right service for you? So we needed to make information accessible, but also to enable people to have choices and keep them in control of what's right for them. And what do you think of the preparation materials? And we'll show you some examples of those. And what are your thoughts and reactions to the evaluation tools, which was a really good discussions around that. So really important to ask those questions. And people had quite strong views about how they'd felt evaluation tools had worked in the past. So actually involving them in service design, really, really important element. If we go to the next slide. Feedback on how to find out about the service. Across the care pathway, staff need to have better conversations. This is what service users were telling us about mental health, and understand how to refer to the new service and how to describe it clearly to patients, because as we've understood from earlier on in the presentation, it's actually quite a lot of overlapping things, and some of the titles sound quite similar. So to a service user without that organisational background, it is more confusing to get into and to understand what the labels actually mean. So really important to ask them in the first place how it should be presented and described. But they also felt that all staff needed to have that understanding, so that it wasn't a patchy response, it was consistent understanding about what service was available. And that went down to the level of actually looking at the screening questions that service users might be asked to sort of prompt and get a good understanding. We looked at various posters, leaflets and packs to encourage women to raise the issues with professionals, including midwives, consultants, health visitors, GPs, postnatal care, so a wide multidisciplinary array of people and where women might present and what information should be available. And women wanted to have conversations about referral rather than use self-referral. So what's the right environment to initiate that conversation? What are the questions that are going to prompt that good quality conversation? And how information might be shared to be accessible. So through social media, through voluntary groups, and also BadgerNet. We're fortunate in the Northeast, certainly in North Cumbria, to have BadgerNet already in situ, and other locations in the Northeast also being implemented as well. So how are we going to use this tool to enable and to reach all voices? The group also made suggestions on draft materials to reduce reading age, which is really important. In the Northeast, we know that literacy rates are the higher percentage of people with low literacy rates, so we need to be very aware of that as well. So all those areas of barriers around accessibility and understanding are really important. We go to the next slide. So this is an example of a co-produced piece of work in terms of describing the maternal mental health service, trauma, loss and fear in maternity. And this was went through the different sort of processes of service user voice input and engagement, and that involved the sort of MVP involvement, but also through the listening workshops as well. And the plan is to have further workshops with different groups of people and different backgrounds, demographics, and different minority ethnic groups also, to make sure what literature is put in front of people is appropriate for individuals and different groups. If we go to the next one. Okay, and this we felt that it was really important to have preparation material to help you consider what might happen at appointment. Very often service users don't really know what to expect at an appointment, so we thought removing some of that uncertainty would facilitate that that appointment. Somebody's not able to see the slides. I'm not sure if that's just I got sight of them. Yeah. Don't know if
I can see the slides fine.
Yeah, okay, thank you. So this is the format that we came up with, hopefully not an overwhelming format. Hopefully it gives some prompts without sort of having a list, and enables people to sort of think and put down what their preferences and priorities are for those discussions ahead. And on the right hand side, there is the summary of that appointment, which again, very often we've all experienced leaving an appointment and remember a couple of things and it gets a bit blurred, and later on we're trying to put it into context. But if we have something like this to sort of guide us and support us and make us feel in control of where it was and give some feedback about it, we thought that is going to add value to that person and feel that they are connecting with the service. Okay, if we go to the next slide. Feedback on evaluation tools. There was good conversations around this, some indifference about them, a plea that the filling in the evaluation thing isn't the be all and end all of the session, and getting feedback is meaningful and has value to the person that's seeking that service. There was a preference for the outcome star, which allowed people to sort of personalise that as well and put on there. I think I've lost the slides now. They're coming back. And liked the idea of personalising goals in therapy sessions and evaluating these alongside the formal tools as well. So really important to put that individual at the centre of the whole process in terms of design, but also in terms of receiving that care and service. And really emphasising that sort of personalised nature of care. Okay, if we go to the next. All right, I think Ange, hand over to Ange now.
Thanks, Sandra. Hi, I'm Ange Broadbridge. I work for an organisation called Ways to Wellness. We're a Vcse infrastructure organisation, so we're often involved in developing prototypes and projects like this that bring together the Vcse and statutory organisations, and often that works with a social prescribing and a health inequalities focus. I'm also a man with lived experience of postnatal depression, so this work is really close to my heart and really important to me. I'm going to share a bit about the value base really and the mindset for this approach to collaboration that we're taking with this work. I think for those of you who are interested in kind of theories of change and design, a lot of this work, certainly with the Vcse, has been influenced by Hilary Cotham's work around prototyping, her book Radical Help, and also the kind of growing, I think it's fair to call it a movement around human learning systems, and people kind of interested in working in that way around kind of being more human, working with learning, and also around system change. The MVP have been a really integral part of the Vcse-based maternal mental health support prototypes. We're working in Sunderland, North Cumbria, Northumberland and South Tees, and Ways to Wellness are working in collaboration with the voluntary organisation network Northeastern, and also with North Cumbria CBS in leading the development of these mental health support prototypes. And I guess that the vehicle for this work is social prescribing link work. That is a model or a support, I guess, an approach to support that really recognises that the social determinants of health account for 80% of all health outcomes. So we're kind of working in that space around holistic well-being, connecting people, women in this case, to local assets, to support them to take control of their own health and well-being. I think one of the things that we heard kind of in the development phase for the prototypes, we went out and did a series of listening exercises with women, was very much this strong sense of social isolation, particularly coming out of the pandemic. So in terms of the kind of support that the link workers offer, as well as kind of connecting mums to assets within the local community, sometimes that is about the very practical things. I think particularly with the cost of living crisis at the moment, there's a real opportunity for the link worker to quickly build trust with a mum in being able to access things like nappies and clothing for children. really kind of putting things in place for mums to be able to access local assets, whether that's sort of food banks or support around benefits and housing. And I guess to kind of go back to that point around social isolation, I think a really key part of the work is about introducing mums, taking mums out into the community, so that if there is a mother and baby group locally, the link worker can go along to the mother and baby group with a mum for the first time or the first couple of times, make that introduction. And just this week, we've worked with our prototype leads to find out a little bit more really about how they're getting on with that work. And some of the feedback was particularly powerful, I think, around that kind of making those links and connections. So we had a mum tell us that after the first opportunity of going along to a mother and baby session, she had this sense of hopefulness. She said she was so hopeful she cried with relief. And I think there's a real strong sense in all of the work that the prototypes are doing that we're really working into that place and space around social isolation, around poverty, around some of the more kind of multiple and complex needs that we've described a bit earlier. The Vcse Maternal Mental Health Services project really kind of grew out of some initial discussions with the Vcse Partnership Programme. That's a programme here in the Northeast that supports the VCS sector to engage and collaborate with the Northeastern North Cumbria integrated care system. And I guess in terms of the design framework for this work, for the prototypes, this looked like not putting a delivery model in place. So really allowing the prototype leads to work at place, to use their knowledge as providers of both their kind of communities and their families, and to develop new supports and services that really kind of meet that need. Next slide, please. So we're prototyping, we're not piloting. There's this real focus for me on rapid test and learn with service user and service provider led design at the heart of that work. I think what we're seeing in terms of understanding local context and building on existing assets, particularly through connecting widely across the local system and working with local MVPs, are that the MVPs are really helping us to both kind of make the connections, understand what services mums are already accessing and really get to understand the gaps. So to give you an example, in Sunderland, our MVP identified a new wellbeing cafe that's set up that has a series of kind of counselling rooms at the back, toys for babies at the front. It's not a structured mother and baby group, but it's a cafe that runs in the community as a wellbeing cafe. So there's a real sense when mums come into that space that they're welcomed in a different way to the way that they would be welcomed if it was a conventional cafe space. And that's proven to be a really useful opportunity for the link worker to meet with mums in the community. And I think that speaks a little bit to what Stephanie and Tash said earlier around kind of safe spaces, community spaces, not always needing to kind of meet in those spaces that maybe feel a bit more clinical. We're very much challenging existing ways of doing things that get in the way of collaborative approaches. And I'll say a little bit more about the mindset for that in a sec. We're building a supportive learning community approach. So we bring the link workers together once a month. They have an opportunity to come together and talk about what they're seeing and hearing in their cases. That's been really helpful. Recently, we've identified that we are starting to see a growing number of issues, for example, around cost of living crisis, and link workers have then been able to identify both some opportunities and some gaps in terms of filling those needs. And very much capturing impact through sort of stories and numbers and outcome measures. And again, I think that's a really nice sort of space of collaboration, because just as the clinical service has been on that journey around kind of outcomes and defining outcomes, we've been on a similar journey around looking at how do we evaluate the impact of social prescribing too. Next slide, please. So in sort of working towards integration of the VCS and embedding this co-production approach and listening sort of in how we work, it's been really useful to try and articulate a set of, I guess, sort of shared values or a mindset for collaboration in terms of the way that we work together. So we've kind of got these 5 mindsets. Yeah, I suspect we'll sort of add more as we go, and I think really nice to sort of see how these tie with some of the mindsets that Stephanie and Tash shared earlier too. Very much about that genuine co-production, elevating the voice of lived experience, about working in that space around active listening. And if we have time, I think it would be great to hear a bit more from Sandra around how the MVP do that active listening. We'll maybe come on to that. Very much about professional curiosity, both to dig deeper but I think as well about triangulating what we're hearing, both across voluntary sector roles, clinical roles, and with service users and carers too. That real commitment to learning through prototyping, so that rapid test and learn. We have had to be quite pragmatic. You know, we've had to get these services set up quite quickly. We have had to take a quite pragmatic approach to how we do things. It is test and learn. So that means if something isn't working, we kind of stop doing it or we pivot and try and do something different. And I think kind of linked to that, having both the kind of task and finish groups and having an opportunity for quick sprints on key pieces of work mean that we're working in quite an agile way as a system too. Next slide, please. We've got a couple of quick case studies to share with you. In South Tees, I guess the way the kind of prototypes have developed is that we've got that real kind of evidence and women's voices at the heart of how we're collaborating. So we looked at both kind of local need and providers' knowledge of their local place, together with the maternity equity assessments locally, to understand kind of health inequality areas of need. And in Middlesbrough, which has a diverse population, the prototype is really focused on the health equity profiles of minoritised ethnic communities. And Hania, our link worker there, has sort of made minoritised ethnic communities her kind of key area of focus, I suppose, in terms of seeking referrals. We've been really fortunate that as this work was getting off the ground, the MVP in South Tees also set up an ethnic diversity subgroup. So the prototype team have really kind of been working alongside the ethnic diversity subgroup, which has been doing work to understand the lived experience of women and families for a breadth of communities within Middlesbrough, and then using that work to really inform how the link work is provided. There were a couple of really key outputs the MVP ethnic diversity subgroup have led on. One is the development of a recruitment diversity film. So they've worked with a group of midwives, I guess, listening to women who said, we'd like to see women on the maternity unit who look like us. So developing a really good film in terms of encouraging recruitment of diverse new midwives. And a report too around women's experiences of labour and birth in the South Tees area. I've got a really quick little clip of Hania, one of our link workers, I guess really sort of talking about how she's taken what she's kind of learned in this space and is then setting up new peer support services in the South Tees area. So I'm just going to hopefully share a quick little audio clip with you now. And I can't hear it. I'm not sure if we should be hearing something or whether other people can hear something.
Yeah, I was going to say the same. Actually, I can't hear it. No.
Oh, thanks so much for letting me know. I'm gonna try and share one more time.
There is a tick box on the share of include sound.
Yeah, I've done that. I'm going to just open in a different. Let me try again. Oh, thanks for bearing with me. It'd be great if we can get this to work. We have sound now.
No, I can't hear it, unfortunately. I guess if it's not possible now, we can share it when we share the slides after the event.
I'm going to try one last time, if that's okay. Best
Yeah, please do.
No, I'm not going to be able to share that. What I'm going to do is make sure that we get the audio clip to you separately, and I won't take up any more time around that, but thank you for bearing with me. And I think I'm handing over to Sandra to talk about North Cumbria.
So, Sandra, I think you're on
mute. Sorry. Okay, the North Cumbria case study. I think one of the things the MVPs brought to the project is our local place knowledge, really, and networks that we have already established, and also our links into maternity and also across the community and with perinatal mental health services locally. The MVP had also been previously closely involved in the implementation of an outreach perinatal mental health service. So we had that experience and networks, and we actually still had a group that was meeting at intervals to actually discuss and share that, because we'd valued that collaboration. But this project has really extended links and strengthened relationships, both over the bigger LMNS footprint, because we've shared that knowledge and information through that network of MVPs as well. So, for instance, the South Tees ethnic diversity subgroup have actually presented at our last maternity engagement group meeting, and we've established relationships there to have that ongoing update, because they were just due to deliver a report on their findings from some of their engagement work, so that we can follow that through, and also follow it through from the point of view to ensure that MVPs are part of that process of ensuring voices are responded to as well, because we have those links into the system and to the LMNS board. But in North Cumbria, we're looking particularly at the moment about a project, a co-production and inclusion project, to actually ensure that the resources that perinatal women have are enabling them to understand exactly what services are available, and that improves their awareness of those resources. So we need to understand a little bit more about what people need in terms of access to information. So we need to understand better how different cultures may interpret maternal mental health and well-being, and we need to understand what barriers to access already exist, particularly in the deprived and minority ethnic groups in our communities. So we have a project that's aiming to look at those specific areas. And as part of that, we want to have a focus on inclusion, and we want to ensure that we'll be amplifying and prioritising the voices from women from minority ethnic groups. And MVPs will have a crucial role in that process as well. And we're part of that small co-production group that has, well, it's growing actually, it's not that small now. It has the clinical lead, it has the peer support group, Happy Mums, who is chairing that taking that role in chairing that. It has Health Watch input, it has digital citizens from Newcastle University, who are giving us some input in design in terms of participatory methods and approaches to use. So it's bringing real new resources to that discussion and ensuring that we will be able to outreach successfully, but ensuring that that learning will be taken forward to design and involve those service users in the design of the service going forward. Very much it's got a person-centered approach at the heart, and it will be about listening and improving pathways, and ensuring that there be some embedded ongoing feedback mechanisms. So once we've established relationships, it's about growing those and linking and increasing involvement in those services, particularly from those voices in the deprived and minority ethnic groups. So as an output, we hope to co-design paper and electronic resources to promote understanding of what services are available, and also to, in that process, to empower choice and improve access to support, because as has been mentioned earlier, we know take up from minority ethnic backgrounds isn't as good as it should be. So we need to work particularly to understand our local population and understand the barriers that they face. And we want to ensure that we gain information and insight about experiences of diverse women around mental health and well-being, and make sure that information is collated and that the services are responding to those needs. And finally, we want to sort of raise awareness in the local communities of issues around perinatal mental health and the support available. So that's the purpose of that group, and we're in the process of moving that forward at the moment. So hopefully that we'll be able to report at another stage, you know, what we're finding and learning. But from an MV EHV point of view, that collaboration with all those different groups is going to be vital in terms of our own need to expand outreach for feedback for maternity services as well, but also it helps us to develop those contacts and relationships and further those. So as part of our contribution to the project, we have this embedded within our current work plan. We've identified where some resource in terms of recruiting an MVP engagement support person, and we hope to actually build that inclusion element in by working with partners within this group to actually support the recruitment of those engagement people to take things forward. But we realise that we, as I said on the slide from Jess, actually alone we can do so little, but together we can do so much. So it's working with partners to bring what resource and skills and knowledge we can together to improve those services locally for service users. And I think that slide, I just wanted to describe this diagram on the right hand side. This is the diagram we shared with Catherine and Rachel early on about co-production and how it looks. And actually, and I think sometimes we like things to look neat and tidy, but actually the most collaborative things are when things are working really well, they probably look like this, but actually it means that we're all on that journey together in terms of having those conversations, generating ideas and finding that space to actually look at things differently and make those connections, but together design a better output and bring people with us and involve new partners and people in that process. So there's great value in doing that. And in actual fact, you probably go through that process several times over as we're on that journey to develop and implement and embed services that are joined up and do meet the needs of the individual at the centre. And the next slide. Okay, I think who's leading on this slide? Okay, so I think if I start off and then I'll hand over to my partners here. From an MVP point of view, I think what I've learned working with partners is actually MVPs are actually quite lightly resourced in terms of honorarium time and actual physical resources. So we do have partnership in our title, and this whole project is really emphasising, and all the work that we will be doing around equity and quality, that partnership is absolutely fundamental to success going forward. And I think what Maternity Voices Partnerships bring is that forum for local co-production that embeds knowledge and connections, but we're also well embedded within the maternity service as well as being part of our local communities. So we have that sort of oversight from being across those roles, but we also have the networks and connections that link us in more strategically with local maternity systems and also ICB. So we have a crucial sort of role in the middle, and we do need to work with partners to identify resources going forward in terms of meeting the needs of specific demographics in our communities. And the opportunity to talk about mental health with service users feels groundbreaking. It feels really important. It feels that we have been on a journey, and that it isn't the service that's less spoken of, it's a service that we're speaking more of, and that the holistic individual-centred approach that's actually looking not just at clinical needs but also support needs that person needs, that supports their well-being, is absolutely fundamental. And having a service that's well embedded with maternity services and community services and has that central knowledge of information that was talked about earlier about having that hub is absolutely crucial. And I feel that we're going a long way in the design today in terms of bringing those things together in a holistic way. So I've been really pleased with what collaborations brought to us as an MVP, but what we've been able to offer as well, and be part of that learning journey to improve those services for people that need that care and support. If I hand over to Ange.
Thanks, Andrea. Yeah, I guess for the Vcse prototypes, what kind of closing the feedback loop looks like is that we're up and running. We have prototype social prescribing projects up and running in the 4 areas. We also run that monthly learning community with the link workers, where we're exploring barriers and the blockages and opportunities. And I think that's very much about kind of continuing to seek input across the system, having support from the system to really affect change. And sometimes that results in ideas for further prototyping, for kind of mini experiments to develop new learning. So it feels like a really exciting place and a really agile place to be working in. Certainly in terms of next steps, we are building the kind of case for service expansion based on the good practice and the system working that we've been able to demonstrate in order to deliver maternal mental health service and to continue to have that desired impact on local population needs for all women. And really sort of thinking about the role of link workers and their impact in terms of their outreach and work into multiple disadvantage. So we've had conversations, I guess, around what might term as the kind of more harder end of this work in terms of working with women around domestic violence, around housing and homelessness issues, around addiction, and thinking about how that kind of support links to maternity and mental health systems more generally. I guess sort of rounding off where we started with wandering with purpose. I think we are wandering, but I think what we've landed on is genuine co-production. And certainly in that sense, it's been an absolute pleasure to share a bit of our journey with you today and look forward to continuing conversations over the course of this morning and afternoon. Thank you for having us.
That's great. Thanks, Ange, Catherine and Sandra, and also to Rachel, who I know was involved in the presentation, for another excellent and informative presentation. That was really great. We are running a little bit behind. I'm still going to suggest we take a 5-minute break now, because I don't just want to plough through. So if we have a break now and then reconvene at 10 to 12, so 11:50, we've got one more presentation and then we're going to go into an open Q&A session. What I'll suggest is, because we are running a fair bit behind, we'll formally end the meeting at 12:30, but we'll leave some breakout rooms open for anyone to continue to kind of, as a chance for people to discuss and make connections after the meeting. We'll close those a little bit after the formal end of the meeting. So if we reconvene in 5 minutes at 11:50. Welcome back. And thanks to our speakers so far. We have one more presentation, then we're going to go into some questions and answers from all the presenters. So I'm going to now introduce Catherine Briers, who's a National Peer Support Manager for NCT, and Holly Turton, who's the Principal Clinical Psychologist at Cheshire and Mersey Specialist Perinatal Mental Health Services. So thank you to Catherine and Holly, and over to you.
Thanks, Robert. I'm not sure if Catherine's... Oh, there she is. You're on mute.
Sorry, I was pressing camera on and it just wasn't playing, but I am here, very much here. The good news is, everybody, that I think Holly and I have got a very similar message to share from the previous presentation. So we'll hopefully put some more broad strokes around the conversations we've already had today. So we might kind of tie up a little bit quicker, because it's lovely to hear that we're all on the same page, isn't it?
Absolutely.
So I'll just share this presentation with you. Where is it? And then we can introduce ourselves. So we'll just come from the beginning. So I'm Catherine Briers, and I am the National Project Manager for NCT, looking after our peer support programmes. We run a number of different peer support programmes nationally to support parents with their mental health. So I'll be talking about NCT's, specifically NCT's Parents in Mind programme nationally, and specifically the work we've been doing in the Northwest when we've been working with the Specialist Perinatal Service that Holly is part of. Do you want to do your introduction, Holly?
Yeah, thank you. So I'm Holly. As Robert mentioned, I'm a Principal Clinical Psychologist and I work in the Specialist Perinatal Service. So it's a community mental health perinatal team. And yeah, as Catherine said, when I think about how we've worked together to support families.
I think just before we start, it's really important to say it's been lovely following the chat through the event so far today, and just the power of these connections when we can communicate and we can make the time between clinical services, the volunteer sector, community organisations, to really kind of hold the family at the heart of providing the best possible care at the right time for them. It's just magic, and it's been so lovely to listen to the conversation so far today to see how incredible the outcomes are for families when we're able to find that time to really network and embrace what each of us can kind of add to the picture. So just to give a little bit more context on Parents in Mind, we have projects running in the Northwest, in the Midlands, in Newham, and also in the Southeast, as it says on the slide there, providing perinatal mental health peer support to local mums, to dads, and to non-birthing partners as well. That support is delivered by parents and carers who themselves have experienced lived sort of difficulties and challenges with their own mental health during the period of sort of that transition to early parenthood themselves. So it's a really authentic and unique space in some ways for somebody to say, this is something that I felt and I'm really passionate about it, and I want to give you the time and space to process how it's feeling for you right now. So we do find it a really kind of powerful tool, and I think something that we talk about again and again within the service is that sort of the idea of a family needing support, but then being able to access it. There can be a big gulf in what that looks like, really, and we hope that we're a service, and we know that we're a service actually that can sit in that space really well to help families process what difficulties with mental health and emotional well-being can look and feel like, and how they can then connect with support to help them through that period. So the talk that we provide the support that we provide is talk-based. And we're very much around sort of reducing that stigma and normalising the difficulties that becoming a new parent, or becoming a parent for the second time or the third time or the fifth time, that can be really difficult when you're changing lanes within your family, when you are, you know, perhaps if these are not difficulties you've encountered before with a previous pregnancy or child, or even just generally within your lifetime, that these mental health difficulties can present for the first time during that period of becoming a new parent. So we want to build space spaces that allow parents to explore those feelings, normalise the challenges of how blooming hard it is to have a little person and so want to do a great job for them and for you, and that not sometimes feel like a natural fit and not feel like it's coming kind of out of your paws. And I think there is such a sense that some of our parents share with us about almost like a unique sense of failure, because this feels like the biggest job you're ever going to do. And when you feel like it's not going quite right, where do you turn with that? And it can feel really stigmatizing. And being able to access community support where the person that's looking you in the eye and having a brew with you says, do you know what, I felt some of those feelings myself, it can really foster a space for good quality conversation when they can sort of explore that with us. But then if there is more additional support required from clinical services, we can build trust and help them to access that as well. So we want to encourage parents to prioritise their own well-being to support and facilitate a more fulfilling relationship with their child. Over to Holly.
Yeah, so we've just got a bit of a slide here about our service, and I guess, you know, same criteria as we've talked about a bit earlier in the Cheshire and Wirral team really, but just that we are offering support. We offer preconception counselling for women and birthing people, so prior to conception they can access an appointment just to think about how the mental health might be affected by a future pregnancy and if they want to think about the medication, and we actually accept self-referrals for the preconception counselling. And then we also offer, you know, a range of support for birthing people who are in the perinatal period. So they're pregnant or they've got a baby under 24 months and they're experiencing moderate to severe or complex mental health difficulties. And the complexity that we might be thinking about is when mental health is impacting on pregnancy, childbirth, the parent-infant relationship. And we also support mums who are well at the moment, but they might be at risk of deteriorating or developing a postpartum psychosis. So we do offer care coordination as well and joint working with other secondary care services if people are already under a service, but they need that perinatal specific support from us. And just to say that we accept referrals from all healthcare professionals, and by that we don't just mean NHS, we also mean Vcse professionals as well, and kind of really open to receive the referrals from the professionals that, as we've kind of touched on before, are out there on the ground accessing the community, and we think that's been something really positive for our team. You're on mute again, Catherine.
Doesn't want to let me unmute today. I think it's Friday and this computer's sick of hearing my voice and it's like, shut her up.
It's put you on mute again. It really, really don't want you to talk.
I'm not going to touch that button again today now. I think I'll keep my hands away. So when Holly and I were preparing this presentation, we talked a lot about, you know, where does peer support sit and how can that really complement? How does it work for us sort of working with Holly's service in the Northwest? How does that kind of sit alongside clinical support well? And peer support, as it says on the top one there, it's been shown to lead to really significant improvements in well-being and quality of life, confidence, because as I said before, we're navigating that space between realizing that you need support and reaching out for it. And this can kind of be a breakwater, if you like, peer support to just, like I said, destigmatize those feelings and know that you're valid in feeling like this and it's okay. And then you can kind of summon the courage to take those next steps. And I know some of the presenters earlier today have talked about how starting to have those conversations can feel really daunting, and within sort of the voluntary sector we can offer quite a lot of time to that sort of space and sort of navigating how you feel when you're saying these words about what right now feels like, and that can be a real support then into empowering someone to have the confidence to then work with clinical support. The second bullet point, I've kind of already talked about that vulnerability and that sense of unique failure where parents really want this to they want to jump out of bed in the morning, they want to be the Mary Poppins parent, don't we all? But the reality of navigating life with a little person who you don't know, you know, and you've got to get to know, it can feel sort of really deflating and isolating when that doesn't feel perhaps that it's coming as naturally and as joyously as you might have once imagined that it would. Shared experiences within a peer support space can really disrupt that service user and provider dynamic. So we can really foster a space of supportive and shared understanding of what these challenges feel like, again, to improve confidence in being able to hold these conversations with clinical services. And then in terms of sort of where we're recruiting our volunteers from, the service itself, it is very reflective of that sort of place-based approach that is very sort of commonly cited in lots of documentation, that we want that kind of place-based approach, and our volunteers are from the local community, so they're able to kind of reflect what is available locally, what the local challenges are, and able to then sort of make those kind of bespoke and personalised conversations with a service user really meaningful, because they are reflective of what's available on the ground. And then lastly there, this sort of terminology, harder to reach groups, I think we need to kind of view that sometimes as like harder to build trust with, because as we said, we've heard from some of the case studies earlier today and some of the lovely sort of lived experience voices that have been shared. It's that when people have kind of repeatedly, whether it's by professionals and services, or whether it's within their own family relationships, when they've been regularly kind of let down and abused by various kind of factors, it's really difficult for them to then come forward and access support in a timely manner. There is often a lot of kind of avoidance or fear or anxiety about, you know, what will be on the other end of me sharing these feelings. And I think that peer support, and when that's delivered from a volunteer specifically as well, it can really normalise that space and build trusting relationships that can then sort of flourish and blossom into that person feeling ready to access clinical support. I'm going to stop sharing this particular slide because I've got a little video clip that I'd just like to share with you. I'm just hoping my computer's going to play after it deciding it was cross with me before. If I just stop sharing that one and just jump onto this video. Share. So this is just a clip of a group of dads that we've been working with in the Northwest, and I just really wanted to share this with you to kind of emphasise how shut down people can feel and how difficult it can be to kind of make those first contacts.
I can't hear him, Catherine.
Sorry. You try again, maybe it's not taking the sound through.
Your kid, which point did you notice you were struggling?
Oh, goodness.
And then one thing I remember thinking was, I'm a bit of a spare part in this whole thing.
When I was feeling low, I'd think, I just need that few hours on my own, get my head straight.
The dream of parenthood isn't always the reality, from struggling to bond to postnatal depression. There's no doubt that baby Rosie is completely adored, but her dad has had struggles with his mental health.
It releases a range of emotions that you can struggle to control over. Combine that with a lack of sleep, anything's possible really. You want to be the best dad you can be, you just don't know how to.
1 in 3 new fathers worry about their mental health following the birth of their children, and a dad in distress can be overlooked. What kind of things do you hear?
Just the generic phrases like man up, like what's wrong with you? Like it's weak to feel vulnerable, it's weak to show emotions.
These dads are using their own struggles to help others open up about what's on their mind. They're now being trained by the National Childbirth Trust, or NCT, to support other men. The pilot scheme in St Helens is the first of its kind.
It's been kind of heart-wrenching and really inspiring, and in all of the baggage and the responsibility that it is to be a parent, which is a complete blessing, but at the same time a real emotional roller coaster for dads as much as it is for mums.
When you've been to the point where you feel like you can't get out of this darkness and is life worth living, when you're going through it, it can be the loneliest and scariest thing in the world. And you do come through it. Your life will be a lot brighter than anyone else's because you've seen the darkness. Now I wouldn't be without this life. I wouldn't go back to the other life if I could.
And whilst the image of what it's like to be a new mum or dad may not be picture perfect now, the dads here say with the right help, they can be the parents that they want to be. Sarah Rogers, ITV News.
Switch sharing back to the slides, but I hope that kind of demonstrates that idea of how difficult it is to step out of that space and to engage. I'll just jump back onto here and then I'll hand back to Holly for this slide.
Yep, so thanks, Catherine, and thanks for sharing that video. Really nice to see and hear some of the benefits of peer support, and I can see there's some nice comments in the chat as well about that. So yeah, we were just thinking about how we work together to support families and what that can achieve really. And the fact that it kind of brings the family at the centre, that's why we're all in this. We've seen so much, compassion and passion from people today. We want to help people, and so can we do that alongside each other? And something we kind of reflected on was how our referrals can run parallel. So it doesn't have to be one or the other and thinking, we're taking work from somebody else or we're trying to push work away from us to somebody else, that we're thinking about where does this person best sit and how can we work alongside each other to support people. And we thought how often, this community support, the support from Parents in Mind will often follow on from our clinical work as a bit of a step down. So we can be working with mums for a really long time. We've been there with them at the most vulnerable, but actually they've made a lot of improvements and they'd no longer meet our criteria. It's very scary for them to be closed and have nothing out there, and to have a bit of a step down, that community support, for us to have those relationships and know, who we're referring them to, and that's going to be a positive piece of work. It's really reassuring for us as well as mums to know that something is coming next when mums don't meet our threshold anymore. But as well as that, sometimes we can be working alongside each other as well, and sometimes people are coming from us to us from Parents in Mind, so they've been at that lower level, they wouldn't have met threshold, but then actually it's identified that things are deteriorating. Of course, then we want them to come to us, as we've talked about, in a timely manner, and if we've got these good relationships, then that's going to come through a bit easier. So just thinking about those kind of social and emotional connections. We've talked lots today about how that is different for Vcses to, perinatal mental health teams, healthcare professionals, NHS professionals. That can feel a little bit scary and a little bit separate. And to speak to somebody where that judgment is not there because people are in your shoes, they're standing alongside you. There's more of that confidence there to be able to make the connections, and then that can kind of come through to us, knowing that we've got the connection with that service. Talked about this a lot today, but just thinking about tackling health inequalities, and as I've touched on, kind of feeling intimidated by that support and that gap being bridged. And we've been thinking earlier today, it's been mentioned about access rates and things like that. Perinatal teams really wanting to become more inclusive. We want to be capturing Black and minority ethnic communities a bit better, and also within our team thinking about neurodiversity of birthing people, birthing people with learning disabilities, thinking about LGBTQ plus communities. So there's a lot of people that we are not very good at getting into our service because it's difficult. There's so many barriers there, and as Catherine's talked about, experiences of maybe being abused, being rejected, that actually it can be very difficult then to kind of put yourself out there. So if you're in a situation where you're with other mums and you feel like they're on the same level as you, that's very different. So as we've talked about, that place-based care and being out there, we often don't get the opportunity to do that. So why not link in with the people that do and help people to access us so that we can get out to that wider community.
Thanks, Holly. And I think coming back to that perspective really around dads and the non-birthing partner, something that we found really effective within our pilot programme for dads and partners in St Helens has been being able to offer sort of mental health support, but without labelling it as such. And I think being able to, within the VCSE sector, we can be quite swift to respond, because we haven't got sort of the layers of governance, if you like, that over practice, where we can quickly sort of foster a different group space, an alternative kind of offer to perhaps what we've been doing before, or certainly what would be available from clinical services, because they do need to be badged and labelled as mental health support. Whereas, you know, we've been running a photography group for new dads, and that's we talk in that group around, you know, let's try and take a photograph of this week for your homework, of a really good connection, baby really connecting well with somebody else that's in the image, or something that's caught their eye in the image. And then when we bring that back and we discuss that the week after, we can really unpick things around that parent-infant relationship and how that's feeling. You know, send us a photograph this week of, like, you know, the most exciting thing about parenthood, the most mundane thing about parenthood, and what the conversations that fosters, without us putting on that flyer, this is a mental health support group. I think we're in a really privileged place working within the community to instigate conversations and engage people with, how are you? How is this feeling? In a way that clinical services obviously have to badge themselves around that clinical need. We can kind of do sort of a light touch opportunity around that, and build confidence around what those feelings are and what's available if you do feel that you need more support. So in terms of barriers, and you know, these have been discussed really well today, and when Koala were going through those, I was like, yeah, we're on task. We've all come up with the same threads, which is really good to see, but frustrating as well that we're all facing these barriers. So in terms of sort of building trust between ourselves and our clinical partners, these are some of the questions that we felt we were presented with quite a lot. So does a non-clinical service have sufficient knowledge of mental health concerns in order to be able to access to deliver quality support? Have we got appropriate safety mechanisms in place so that we can hold people who perhaps may deteriorate within our service? What quality of care can a community service provide? What level of accountability is there for a VCSE? How do we build trust in the way that service users will be held? What geography is covered? We've already talked today quite a lot around short-term funding and the instability of the landscape, really, and sort of how do you kind of continue to sort of thrive within those partnership networks when you don't know how long you're going to be here for? We've had lots of questions around data sharing barriers. You know, how do you communicate referrals between an NHS organisation and a third sector organisation? There's kind of lots of layers of governance around that can feel really tricky. How can we accept direct referrals into secondary mental health care from a VCSE? And that's something that Holly mentioned before. Within the Northwest, Parents in Mind have always been able to make a direct referral into the specialist perinatal service, and that has been just so incredibly powerful for the families that we have noticed a deterioration in. Being able to make an immediate and trusted referral into that secondary care has been huge. And I know that across Parents in Mind, there are other localities that we deliver where that's not been possible, and I think we really need to look at our structures in that sense, because if that referral has to come from a GP or a health visitor or a clinical professional, there can be such an amount of time wasted in getting that person the support that they need, but also that person that we're trying to connect with secondary care can just completely sort of shut down, and they can already feel let down. And we've talked a lot today about having to retell stories and how triggering that can be for people. It's a huge benefit when we can really work collaboratively and with sort of trust and sort of that common training and common knowledge of where our thresholds and our criteria sit, so that we can find speedy intervention for people. We're often asked how we can sorry, I've done that one. We can also see obviously from the VCSE side that clinicians are already really stretched, and that's one of the barriers really in sharing information about third sector organisations, because there's often no time to learn about or liaise with another service when you've got a really, really busy caseload. I know that within lots of clinical teams that we work with, there can be quite a lot of staff turnover, or people maybe work part-time, so it's sometimes really hard to share those messages. But what we would say is that if we can be proactive about doing that, then it can really kind of lift some of the load of the pressures that caseload, when you know that there is a really good quality partnership with a VCSE there that can take up some of that capacity to hold those conversations in that space with that person. VCAs can sometimes as well be funded by our clinical partners. So there are sites where we particularly are funded by the clinical service that we're working in partnership with, and that can really kind of make it difficult to kind of communicate about improving practice and what's going well and what's not going well. And I've just put on there that kind of don't bite the hand that feeds you. That can really feel really difficult sometimes. But I think when we move into the next slide, we've tried to kind of think about what are the pillars that underpin answering many of these questions. What are the kind of key takeaways really from what Holly and I have shared, but I think really from across the morning, what are the things that can kind of really help us break down these barriers?
So this is a bit about how we make it work, and I guess, you know, the key to this for me and Catherine is definitely it's about relationships. It's about us knowing each other, communicating with each other, having that open communication always. That has made it really helpful for us in kind of working together. So there's stuff there around mutual respect. I guess everyone that we've worked with from Parents in Mind has just really got this sort of compassionate and enthusiastic approach, and that's just lovely to be around. And then, yeah, I hope that us as a team kind of come across as a compassionate team, that we are open to hearing from other services, and that we've got that, you know, respect for each other and a kind of interest in each other's services and what we can do differently and what we can learn from each other, not kind of trying to separate ourselves. So yeah, we invest time engaging with VCSEs, and there's so much to gain, as it says there, for both of us, you know, if we're able to connect. And I guess one of the things that Catherine highlighted, you know, in the previous slide, is it feeling like that time's not available, but actually often it's going to save you a lot of time in the long run if you're getting to know each other with clients. But also just when we're thinking about signposting, if you already know the service, it just comes to mind straight away if you've built up that relationship. And we've been able to work together, you know, share support, share resources. Me and Catherine have kind of chaired a network meeting around parent, infant and perinatal support across the 4 boroughs that our team works across, and that's, you know, attracted people from IAPT, family nurses, health visitors, and yeah, VCSE you know, services as well. And that's just been a really helpful way of us thinking about how we improve services, sharing information, sharing resources together, sometimes discussing cases, whatever we want to bring. And that's something that we've kind of been leading on together, and that's come from that relationship that we've been able to build. Something there about the access rates, and I know that we've talked about that, but we do tend to, in the NHS, you know, have these key performance indicators around access rates, and that's really important to us to reach as much of our community as possible. So why not help each other, and VCSE can help us improve those access rates because they're out there in the community with these people. And yeah, over time it can aid clinical staff capacity. You know, sometimes we are checking in with people because we feel that they need a bit more of a frequent check-in, but actually that doesn't necessarily need to be from a secondary care mental health service. If we know that Parents in Mind are also checking in and linking in with these mums in between, then that can give us more time as staff to be supporting more people. So that's a real positive, and of course might be more of a positive experience for the client, because, you know, thinking about my role coming to a clinical psychologist and doing therapeutic work is a totally different relationship from being with a peer support worker. And I know we've got some peer support workers on the call today, and you'll know that there's just a different sense of connection there and understanding, and that lack of you know, feeling judged and knowing that that stigma is not going to be there. It is a totally different relationship, so we should be able to give clients an experience of both. So yeah, we've tried to get integrated pathways in place and learn together. And I think, you know, little things that we've done, like Catherine has, you know, we have huddle meetings every morning, so the whole team's there for like 20 minutes, and Catherine's just nipped on and done a 5-minute, like, okay, this is where we're up to with Parents in Mind. Hello, any new staff, everyone in our team, knows who Catherine is. When Catherine was on ITV, that's in our group work chat, like, have you seen Catherine? Get the news on, because we all know her face, and that is just so important. I think that relationship and just knowing that you've got somebody to ring, and hopefully the same for Catherine, that she's always known there's people in our team she can check in with if she wants to think about a client or a referral, anything like that. So really just being open and connected. And yeah, of course, we've talked about this a lot today, but we're placing the service user above everything else. So us being compassionate towards each other, that's going to filter out into the way that we're supporting people, but also it's going to provide them with a better service, because we're trying to get the right thing for everybody, and we're thinking together. We're not just kind of putting people into categories of what we think they need, and being that proactive and creative, you know, as Catherine talked about before, some of the ways that VCSEs can deliver a service is just totally different and so much more accessible. We've got to think about the diversity of our community, and we're not always able to offer that creativity in the same way. And we could be standing there saying somebody needs some, you know, trauma therapy, and actually they're saying that's not part of my culture and the way that I see the world, and I would rather access support in a different way. So we can learn from VCSEs around some of that as well, and the fact that if we are kind of working together, reaching out, trying to think of ideas, that is going to work better for us in the long run in terms of the time. So yeah, hopefully that is just a helpful overview of why it works and how we've made it work together.
And then just in terms of sort of moving out of this session, we obviously have put our names and contacts on there in case you wanted to follow up on anything we've spoken about, but I also wanted to acknowledge Dr. Vicky Selby, who looks after the Silver Birch Hubs, which is the maternal mental health service for Cheshire and Merseyside, because I said to her, have a look at these slides, Vicky, and put your maternal mental health service hat on and see if there's anything different you would add. And she's completely agreed with what we'd said, but she said, can you please make sure at the end of the discussion you tell everyone that this integrated way of working, this mutual respect for clinical, for community, for voluntary sector organisations, it's not just good practice, it's essential practice in order for the family to really achieve their full potential and to thrive. We absolutely need to be open to these conversations, and you know, I know that nationally that happens to varying degrees, but I really thank the Northwest Specialist Perinatal Service for being so open and accommodating to us, because we know we can share in those absolute high five moments of families getting exactly what they need at the right time, and us all kind of playing our part in that jigsaw, really. So thank you for listening.
Thank you.
That's great. Thanks, Catherine and Holly, for another really great perspective, particularly on the benefits of peer support and effective working between clinical services and the VCSE sector. That was another fantastic presentation. I'm going to ask now all presenters to move into the virtual rooms to answer any questions that were raised in the chat. I know we've answered a few as we were going on. I'll try and wrap up by past, but I've got a few questions I think that we have still to answer. So firstly, a question for Lucy from NHS England, and this is about I guess data and demand. So in terms of maternal mental health, birth trauma, PTSD, where can we go to look up to get data around number of women or birthing people this impacts?
So prevalence in this area is not as straightforward as you might hope. So we can point people to the most recent research evidence, which I don't have at my fingertips, but Zoe Oliver and our team can help hook people up with. But yeah, there's ongoing huge difficulties around, because it's such a difficult time for women to come forward. And so really understanding prevalence compared to just women who are presenting at services is an ongoing tricky thing. But certainly, Rob, we can share through you if you want to then share on with people.
Yeah, that'd be great. Yeah, we're happy to share sources with people, with participants after school. That's great. Thanks, Lucy. And another question for you, which was answered earlier, but it'd be useful to get your perspective on it. And this is around national guidance around lowering thresholds for service access for families from communities where there's likely to be significant pre-existing trauma.
So I think rather than thinking about it in terms of lowering threshold, I think it's really important to think about how we understand complexity. So our services like the Cheshire and Mersey team we've just heard from, therefore women with moderate to severe or complex mental health, perinatal mental health needs. And that complexity could be historic, social, economic. And so if you're working with a group where there is that kind of complexity, and doing the outreach is so important. So I think of it as it's not about lowering threshold, it's about understanding the life situation of those families. And while I'm off mute, can I just say it's been so amazing to hear from all the teams. I know that teams are doing just wonderful stuff in partnership, and it's just, yeah, it's amazing. So thank you for having me.
That's great. Thanks for that, Lucy. The next question I think is probably for Nat from Hearts and Minds Partnership, if you're still on the call, which is someone said they'd be interested to know what your standard questions are around governance that you mentioned, so safeguarding policies, etc.
Yes, it's a very good question. Thank you very much. I think it's important how we frame those conversations. It's something we've talked quite a lot about at Hearts and Minds. So it's not being about policing the sector in any way. There's a checklist that you automatically have to fill if you're a service via our website in order to feature on the map, which asks some standard questions about service provision, the makeup, the audience, what you're offering, where you're offering it. And then at the end, we've just got some questions around protecting your service and protecting your beneficiaries, which will be around things like, do you have an adult unchild safeguarding policy? Do you have you explored DBS eligibility if you are working with people who are vulnerable? Do you have supervision in place? And that's really to start a conversation for emerging organisations who might not have those things in place, to really support them and help them to get into that place so that they can feature on the map and they can then go for funding, because those things are sort of essential for a foundation for growth. So I hope that answers the question.
That's great. Thanks, Nat. The next question is for the North Cumbria teams, Ange, Catherine and Sandra. And this question is about how you work with your local primary care mental health teams and how you ascertain which service, MMHS or perinatal psychology, offers trauma interventions under different circumstances.
Hello. So what we've done is we've got a I guess an overall system pathway that looks at different levels of psychological care and psychological input, which helps to provide some differentiation in terms of what different services can offer, and that applies both to NHS services and non-NHS services as well, and also to all healthcare professionals across the maternity pathway. So an acknowledgement that psychological care would be the business of everyone across the maternity pathway, whatever professional background, even if it, around having, I suppose, appropriate using appropriate communication and having those personalised care conversations. And then in terms of just around the NHS mental health services, we've got a diagram that would give some indication around which people would be most appropriately, or whose needs would be most appropriately met by different services. So that gives us a starting point. In reality, it doesn't always fit into those neat boxes, of course. So then what we would do is have those conversations at a local level. So we pick up the phone to our, for example, to our various local services to have that discussion if it wasn't entirely clear where the person would have their needs best met. And also what we try and do is if someone's referred into one part of the pathway, so for example into maternal mental health, perinatal mental health, or into IAPT, rather than bouncing back to the referrer, which we don't want to do because that's adds more work and wastes time for the person as well, is we'd work it out between us in terms of where someone would then best sit. Hope that answers the question.
Yeah, that's really great. Thanks, Catherine. And then a question probably for Holly and Catherine from NCT, which is around how do we support staff and peer supporters who work in perinatal mental health, maternal mental health, with their own experiences of trauma, fear, or loss that may come out in the course of their career if re-triggered when supporting a family?
Within our peer support sector, we do have a clinician that supports our project. So obviously we're a non-clinical service, but we offer accredited training to all of our volunteers and obviously to our staff team as well. And part of that accreditation is obviously peer support is very much that side by side. So the service user wants to hear you share something of your lived experience. It isn't kind of like just a space for them to talk. They want to hear very much the perspective of the person that's listening as well. And that can be a big part of that sort of normalization and validation within that space. And we make sure that within our training program that we gradually sort of expose our potential peer supporters to what these conversations will look like, and they use a lot of their own lived experience and explore that within the safe space of the training with the ongoing support of a clinical supervisor as well, so that we can kind of unpack things that come up. And we have had people who have taken on the opportunity of training and been really interested in doing that and actually found in that process, I need more help myself. I'm not quite ready to take that on from somebody else. And that in itself is a win, because we've found somebody else that we've been able to connect with, support and help them uncover something perhaps that was unresolved. So that's how we manage it within Parents in Mind.
Yeah, and similar for us, really thinking about offering that clinical supervision, which is provided to all of our team as health professionals, and also hopefully like to think the peer support workers that are employed within our team have got good relationships with us in psychology as well, and we can offer that more informal support rather than kind of a booked in structured supervision, if it would be helpful to talk through cases.
That's great. Thanks, Catherine. Thanks, Holly. I think we're pretty much exactly at past now, so I'm going to formally end the meeting there. So thanks so much for all of the presenters today and for everybody for your engagement in the chat. I think there've been a series of absolutely excellent presentations. I've popped a link in the chat to a short evaluation form, so would be really, really grateful if you could spend a little bit of time just filling that in after the meeting. We were supposed to have some breakout groups. I mean, the purpose of the breakout groups was effectively just to give a chance for people to discuss and make connections and share examples of individual things they're involved in. So whilst I'll formally end the meeting now, because we've come to the end of our time, we're going to still open the breakout groups for 15-20 minutes. So anyone who wants to stay on to join one of the breakout groups, please feel free to do so. But otherwise, just thank you very much for everyone for joining, and thanks again to the speakers.
Thank you.
Thank you. Thank you very much.
Thanks, everyone.
Thank you. Thank you so much.
Celeste?
Yeah.
It was just me in a breakout room, so I didn't want to be rude and just go, but I'm going to probably head off.
Okay, if you wanted to go into it, then I can put you into a different room, but otherwise, feel free to go.
Yeah. Oh, thank you so much, Celeste. And yeah, thanks for organising, and I hope you're okay.
Thank you so much.
Bye.
Bye. Bye.
Bye.